Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Patrick Qualtire. Dr. Qualtire is a good friend of mine and a neighbor and a really respected colleague. He has, over the last several years, had a dedicated focus into reconstructive hallux valgus surgery, which is minimally invasive, or let's call it small incision surgery. He goes into some of the nuances that I think you'll find very useful and interesting in his overall philosophy and methods of reconstruction of hallux valgus deformities. I think you'll enjoy this conversation that I have with Patrick, and I look forward to more of these conversations after we had such a great conversation this time. So without any further introduction, here's Dr. Patrick Qualtire. I'm here with my friend, neighbor, and colleague, Dr. Patrick Qualtire, and I've kind of nicknamed him after just the pre-conversation chat, the heretic of hallux valgus, and I think we're going to have some fun discussing this today. How long did it take you to get up here today? Was a lot of traffic?
I'd say about 13 and a half seconds.
Okay. All right. Good. So busy day out there on the
Yes.
on the road. So, well, thanks for coming up to the top of the hill today and hanging out. We're going to have some fun. Let's talk about what you've been doing with minimally invasive hallux valgus surgery.
Sure. First of all, thanks for having me. And I'm sporting my Georgia mountain band look for the winter here.
Well, that's good. That's good.
So I first, like most surgeons of my era, I sort of trained traditionally with traditional open bunion surgery, basically.
Right.
Various approaches. I don't know, there are 30, 40, maybe more types of bunionectomies that we have available to us now as far as procedure choices. And then I was exposed to some minimally invasive type procedures. And it just sort of naturally made a little bit more sense to me. Also, with my patient population, I found out over time that, people, they don't want the large incisions. They want early activity. They want to get back to sport, back to activity as quickly as they can. And this just seemed to make a little bit more sense to me, actually. And then I tried to quantify it more.
Right.
So what utility is this going to serve for certain types of patients and certain types of patient populations? And now I've done enough of them, and I've trained on various implants that I've sort of got my head around that a little bit with some experience. And we can talk today about some of what I've learned and where I'm going with this.
Yeah, no, I'm very interested in that. Let's talk a little bit about the history of minimally invasive surgery, because when
Sure.
I was starting my training, it was very poorly appreciated, and with I think relatively good reason, because there were a lot of people, even though the techniques at that time might have had a good medical indication and were the appropriate thing to do, they were being done by people who were less than ethical and violated some of the standard techniques. But then fast forward another 10 or 15 years from the early 80s to the mid 90s. And then it seemed like Europe picked up everything, Mariano de Prado. And then after another 15 or 20 years of this really kind of taking a foothold, no pun intended, in Europe, then it seems like now the United States is getting back on board. So give me some of your insight on that.
So when I first sort of came out of residency, I was affiliated with a practice where we had one of those old time surgeons that did a ton of minimally invasive surgery back in the day.
Right.
Sort of where he was coming from was during that heyday where minimal to no fixation, pin
Right.
fixation at best,
Right.
usually no fixation.
Right.
And they were kind of the masters of splintage to
Right.
sort of manage these patients postoperatively. It's kind of come full circle now where the MIS philosophy has had a resurgence, basically due to the fact that now we've kind of married AO principles for stable internal fixation with the philosophy of minimally invasive approach, specific instrumentation, that sort of thing. So, yeah, I would kind of liken it to in orthopedics, sort of, arthroscopy.
Right.
So now, I think when I first started doing ankle scopes, we didn't have, I'm not sure we had any manufacturers that had specific instrumentation for it. I was always running to the shoulder sets or whatever to pull out some kind of burr or whatever. Now we've got interest from the manufacturers to build devices and build instrumentation that makes sense for this. So I think now you're seeing the outcomes that are a lot better, and frankly the quote unquote abuses that may have been going on back in the day, they'd be hard to do today,
Right.
Because you got to work to screw these up now.
Yeah.
So.
Well, and I think when you talk about minimally invasive surgery, and again, I think this is what was a lot of the problem back in the day, is that there are some things you can do very well without any fixation, lesser metatarsal osteotomies,
Sure.
percutaneous Aikens,
Tailors,
very
bunions,
well.
even.
Yeah, and you splint them, and you're externally, just as if you would fall off a ladder and break your arm. If the bones weren't terribly displaced, they put you in a cast, and Mother Nature heals it up. So where I think they got in trouble was not fixating some of the hallux or let's say first ray, and then it was a disaster with non-unions, delayed unions.
Correct.
And
as we'll see here, even with the types of constructs we're putting together now, we do have a longer period of time where we see that new bone consolidation, and we're going to talk about that as we get into this.
Yeah, I'm anxious to see a couple of your x-rays.
Sure.
And I think the other thing too is that traditional training is so focused on what does the x-ray look like?
Correct.
And people don't factor in that you have to look at this, what's it going to be like a year down the line? And
yeah, a wise older surgeon told me when I was training that, remember, patients don't have x-ray vision.
Right.
And his point was kind of precisely that. And we're going to talk a little bit to these x-rays where we're going to use a concept of effective metatarsal alignment rather than true metatarsal alignment. And I think that factors into some of the procedure choices that we make. Definitionally, because I know there are folks out there, the doctors out there that are really precisely trying to manage these definitions. Small incision versus percutaneous or minimally invasive, all these, I kind of use them all interchangeably. But I guess realistically, percutaneous, really, when we're talking about these types of approaches, is going to mean poke hole incision.
Right.
Poke hole surgery, keyhole surgery, all those types of terms that we hear. Small incision to me is smaller than you would do if you were doing a chevron, a chevron Austin type procedure or whatever procedure you were going to choose. So small incision to me is big enough to put the implant in.
Right. And not necessarily, a violation of a lot of the capsular
Correct.
structures, the soft tissue.
Correct. And we'll talk about that instrumentation as well. I mean, you could certainly, when we talk about osteotomies, of course, you can use a small blade on a saw.
Right.
I really hardly ever use a saw anymore. I use a burr. And I think there's some advantages to using a cutting burr here.
So you're using like an Isham side cutting burr?
Or a Shannon type burr.
Right.
I'm less intrigued by that, other than making sure that the whole cutting portion of that burr is inside where I want it to be. So, one of the pushbacks I get or questions I get is, oh, you're tearing up all the capsule, you're tearing up the soft tissue. And really, if you do this correctly and you get a feel for it, you won't be doing that.
Right.
You're gonna be, the cutting portion of your instrument is not going to be in that area. It's not going to be in that zone.
Well, and the other thing too is when I first started looking at this, this would have been probably about 2005, 2006. I spent a fair amount of time in Spain. I was over there training folks in endoscopic procedures, and they said, "Hey, you've got to look at our minimally invasive stuff." And I was kind of horrified because I was traumatized from the early mid 80s, you know, but then I started looking at what they were doing. And one of the really interesting things was the design of the Isham burr was such that it would cut osseous tissue, but it really wouldn't cut the
Correct.
soft tissue. And I actually made a video. I hopefully I can fetch it from the archive somewhere, but in a cadaver lab, I took that burr and I tried to actually cut through the extensor hallucis longus.
It's impossible.
Tendon. It wouldn't cut it.
Yeah.
And it was amazed. And then the other thing about the saw versus the burr is that the Europeans talk about that you get better interdigitation because you have a little bit of an irregular cut that kind of
Correct.
kind of like Velcros a little bit, for lack of a better way to say that. So I think there's some advantages to the burr.
And there are different approaches as far as making that osteotomy. So, and we can talk a little bit about, and it's important, maybe I'll bring it up now. It's important, I think, if you're exploring this, if you're new to it, really to find a mentor that has some experience in it. And if you can find a mentor, there are also videos. I should probably make some interoperative videos myself, because a lot of it is, how do you hold things? Where's your hand position? How are you using that instrument? How are you controlling the instrument with negative pressure, that sort of thing? And you can do chevron cuts. You can do straight cuts. You can do all kinds of things with the burr. So I think it's important, if this intrigues you and you're looking to do this type of surgery and you think it'd be beneficial to your patients, is to get to a good cadaver lab. I'm sure all the reps will be happy to invite you to a cadaver lab and you can get some hands-on experience. I've taught several of them here. And one of the things that I show very quickly is when I make the cut, I over-exaggerate it. And really, it's almost like I'm trying to make that burr come to the top of the foot.
And it won't.
It won't.
Right.
And then we opened it up with the cadaver. You can see there's really no damage to the internal tissue structure. You can put it on your hand even. So the instrumentation, now if you're using a saw, obviously you've got a different set of concerns there.
So one of the things that I had to do because of just what I felt was intraoperative quality of maintaining my cut was with lesser metatarsal osteotomies, because what I saw in Europe was when the burr was used, there was a lot of jumping around. So you would go farther proximal than you wanted to on the metatarsal, various things. So then we started with a very small incision and then just used a long regular saw blade, kind of a skinny blade, and we're able to control that much better than you can control a side cutting burr. The interesting thing was then with the wild type osteotomy, when we proximally migrated that head, there would always be the overhang. And so just from keyhole or percutaneous, whatever term you want to use, you couldn't take that overhang off. And so I'll actually take that off. I'll leave all the capsular structures together and then just take that overhang off with a little rongeur. It's still very minimally invasive, but that was an adaptation that I had to make, I think, because I just didn't feel that comfortable with the side cutting burr.
Yeah, and maybe in some of these radiographs or pictures of radiographs, you might see some of that in my cuts. We'll talk a little bit about learning curve.
Yeah.
And, there's a learning curve to everything in life.
Right.
And you may see some of that little overhang. I know I've gotten a lot better controlling my burr and cuts and making them more even, if you will.
Right. Well, and I observed some of the true masters over there, Mariano de Prado, my friend Edward Rabat, and they're artisans. They are true. What they're doing is such a level of artistry that learning curve is like really steep and really long for them to get to that level.
And I think that if you have access to anybody who maybe had access to the MIS procedures of prior years, the first thing to do is watch how they place their hands and how they hold the foot. And a lot of this revolves around that, just how the room is set up, where the x-ray is, your mini C-arm, et cetera. And this is a two-handed dance that we do with this. Right. So you really have to have somebody else that's taking your images and that sort of thing, even though basically the setup is to have the C-arm basically in your lap.
Yeah, well, it's not easy surgery. It's very difficult. It's technically precise.
Yeah.
And yeah. So, let's talk about some of the things you're doing for Hallux Valgus.
Let's jump in here. So let's talk a little bit about this quote unquote heresy. So to me, I like the word heresy, but heresy is a little bit maybe of a strong term. What I'm really talking about, I guess more professionally, is a paradigm shift. Right. So this is a new old approach to this small incision type surgery. I remember I taught a lab here in Greater Atlanta, and it was an interesting group of people. There were new doctors just out of residency. There were doctors in the middle of their practice cycle, and then there were some of the older doctors that had been around for a while. And there were definite patterns in the room of how people related to this. And in general, the folks that have been around a while were disinterested to horrified, somewhere on that spectrum. It's a hell of a lot easier when you splice something open and cut through 15 layers of tissue and get down to a bone and just see everything you're doing. Right. Yeah, I get it. I think also if you trained in any kind of trauma environment, which I trained in a level 1 orthopedic trauma center in an orthopedic division, and you got to get used to doing things on an x-ray and doing minimally invasive and lining up holes and shooting percutaneous screws, et cetera. I think that kind of takes the edge off of this.
Right.
So if you have that experience, as soon as I think you're going to gravitate this a little more easily. But I guess we start out with two things: anatomical considerations, procedure choices, and then also, I didn't put it on here, but patient selection. So we'll talk a little bit about that. So as with most surgeries, if you pick the wrong procedure for the wrong patient, the chance of a good outcome is less likely. So here's where we get into some of the heresies. So the days of, no offense to my professors at the California School of Podiatric Medicine, but yeah, I probably haven't drawn angles on an x-ray, printed x-rays in a long time for Hallux valgus surgery. The intermetatarsal angle, even PASA, DASA, whatever you want to call them, DMAA, whatever, have limited utility here because of the kind of surgery we're doing. To me, I look at several factors for whether or not the patient is a good candidate for the smaller or minimal incision surgery. One is, how flexible is their forefoot? How big is the IMA as far as large to, the Grand Canyon large?
Well, let's talk about that so that we're on the same page. Now, back in the day, if you had an IM intermetatarsal angle of 15, then that was kind of an arbitrary point to jump into more of a proximal base wedge osteotomy or a lapidus, something like that. So give me some angles. They don't have to be exact.
So small to moderate. So you'll hear this in some of the folks that are talking about this type of surgery or panel discussions, that sort of thing, where, this is great for small to moderate IMAs. I disagree. So yes, it is. Right. as are other procedure choices as well, distal. But I think this procedure does great for relatively large IMAs, as long as that first ray is stable. If you have a monster IMA,
what are we talking monster?
So 22, something like that or higher, above 20 even. And the reason you got such a high IMA was that your forefoot is super flexible and your first ray is hypermobile. Right. then then this is probably not a great procedure choice. At that point, I'm probably really thinking about more of a Lapidus type procedure, first MC fusion type procedure. Now, I have taken some folks who are pretty flexible in their and this is a discussion that's gone on forever, right? Well, how do you quantify forefoot or first rate flexibility or hypermobility? And it's kind of, you know it when you feel it or see it, right? Mm-hmm. So yeah, I'm not sure that trying to nail it down to number of millimeters or degrees or whatever is really that helpful. It may be interesting academically, but I'm not so sure in the real world it's going to help you in choosing whether or not to do a small incision surgery to the distal metatarsal. So basically that's, if they're too hypermobile, I'm probably not going to do this procedure on them.
Okay.
However, I've taken people that were pretty flexible in their forefoot and done this. It's worked great. There are challenges intraoperatively with it. And we'll talk a little bit about that maybe when we get to a couple of slides that show some
So that's what you're
X-rays.
referring to when up on your slide when you're talking about forefoot flexibility.
Yes.
So that's just there's, to my knowledge, there's not a grading scale. It's just one of those things where your clinical exam, you look at it, how much movement, how much flexibility. It's kind of an arbitrary determination by the surgeon.
Mm-hmm. So if your first ray is if you feel that it's abnormally flexible, or the forefoot's abnormally flexible, you don't have a big metaductus. When you make this osteotomy, the through and through osteotomy, you're making a DeRado or a Mitchell. I'm not sure if I'm even picking the right names anymore. But you're basically doing a straight cut. So now you have a capital fragment that's completely separate from your metatarsal shaft. In patients that have a significant forefoot flexibility, that thing will swim all over the place. So controlling that becomes an issue. And I've had some challenges in certain surgical situations. So, and sometimes if I am going to go cheat it so that somebody's a little bit more flexible than I probably want them to be, I'll run a provisional wire into the capital fragment
To hold it while
and control it, just to control it even during the osteotomy. Right. So it adds another layer of complication on how you hold things, because a lot of this is the technique. And once you get familiar with the technique, I mean, you trained with DePrado and those guys, it is a dance. It is an artistry. So once you get the feel for it, then you're going to get more comfortable with it. This is not, two rake retractors, two sends, and you're standing a mile away and hitting it with a saw. This isn't that. This is, you're controlling the position of these component parts of this bone as you fixate them. And that's one of the benefits of it, is you can put the damn thing wherever you want it.
Right.
So, and there's a lot of positives to that in correcting some deformity.
So then if you're doing a Mitchell, or basically let's just call it a vertical osteotomy,
right,
that has no configuration for stability, because you're banking on the stability of the fixation mechanism that you're going to use. That also allows you now to address any varus or valgus rotation.
It does.
Right.
And it also helps with sesamoid positioning and that sort of thing. If you watch some of the videos or you train with some of the manufacturers, they're going to want you to try to make that with a burr, to make a chevron osteotomy, so you can control some of that motion.
Right.
There is a sort of a balance in this procedure with doing things kind of almost free-handed, if you will, as opposed to controlling it. The manufacturers struggle with this because obviously they'd like to have a lot of doctors doing these things, right? But a lot of doctors need things to be stable.
So let me ask you a question about osteotomy orientation. I would imagine, and I don't know the answer to this question, I would assume that with a chevron or some type of a V-shaped osteotomy, that you wouldn't be able to get as much lateral translation as with a more of a Mitchell type of an osteotomy.
So
As well as, not to mention, you're not going to really be able to get a lot of derotational effect.
Correct.
Too.
So, and I think that's the key. So you're not going to get derotation, the benefits of derotation, and you're not going to get the benefits of adjusting your pasa, dasa, or pasa, I guess.
Right.
And then the lateral translation, on paper, you should be able to translate it just as far, right?
But it doesn't work.
But it doesn't work that way.
Right.
And I'm not exactly sure. It's little old me here in Atlanta, Georgia, and I'm not part of an academic program or academic center. So, but I would love to see some academic work done and some research that shows, is this a ligament issue? What are we doing? The collaterals, palliant, what's holding it up, basically, in cadaveric studies. At the end of the day, it doesn't make much difference to me as far as making this happen. But what I'm looking for is, and we'll talk about it a little bit, I'm looking for maximum translation. Right. Almost every time. There are some times, and we may even have a slide that shows where I didn't do that, and there's some reasons for it. But in the vast majority of cases, you're looking to translate cortex to cortex. Quick kind of funny story. So I just did several of these at a local hospital here a week ago, and just before Christmas. So I'm kind of antsy to get out of the hospital, and I make it a habit to stay in the hospital till all my patients are ready to go home. So it's getting kind of late in the evening, and I get called by the radiology department. Mm-hmm. And one of the senior radiologists, who's been around a long time, calls and says, "I got bad news, doc. I think your plate dislocated and it shifted." Yeah. And at first, I had that heart flutter, but then I got it. So then I went and looked at it. The screws are intact. So I described to him this was a new procedure. So when you see these, and if this is the first time you're seeing it on an X-ray today, it's going to look extreme, weird, crazy, all the adjectives, right?
When I first started seeing some of Mariano de Prado's work, I'm looking at these X-rays and I'm scratching my head going, my God. But I spent a week with him, and I was able to see some patients that had come back for their other foot, that they had the first foot done 5 years ago. And he had this beautiful catalog of these X-rays serially. So he could show how bad, in quotation marks, this osteotomy looked by traditional comparison. And then at 1 year, you look at it like, wow, the surgery was a small part. The human actually healed this thing incredibly well.
It's more solid than when you were born.
Yeah. And so you're right. When you look at these things, I mean, I've sent some of my colleagues some just very simple percutaneous Aiken osteotomies with no fixation. It looks like the Leaning Tower of Pizza, where we're just kind of moving it and impacting it a little bit. And you look at it on X-ray and you're going, what in the hell is that?
And in these cases where we're doing sort of this distal procedure with an implant and an Aiken, and we'll talk about sort of how often I do Aikens on these or find I have to, that Aiken heals immediately. I mean, not immediately, but
it's
quickly.
4 weeks, 5 weeks. It's unbelievable.
Less than that. So I'm showing patients X-rays, and they're not going to see that bony consolidation across the primary osteotomy site, but the Aiken's totally solid.
Right.
So, and that goes to your point.
So let's talk a little bit about sesamoid position. I think there's a lot of myth in this myself, but tell me where you're feeling.
So to me, by the time somebody gets to me with a bunion deformity, and not all bunions are the same, right? We know that. In some cases, this is a bunion / hallux limitus situation, maybe. So the sesamoids range from just out of position, but looking pretty good,
right,
to completely jacked and arthritic and probably fused to the underlying bone, and no sesamoid apparatus worth a you-know-what. So a non-functional one. So in cases where it looks like we've got a functioning sesamoid apparatus, and I test this. So before I put the patient under tourniquet, I take some X-rays and range them, and go live and range them and see what we're up against. I do it. I can't do that in the office, but I don't have a mini C in the office. But and that kind of triggers it for me. So if I can fix that sesamoid position to make it better because I have this, straight cut, right?
Right.
So in a coronal plane, I can move this thing any way I want. I can just rotate it and control that rotation and get the sesamoids back into position.
Which with a chevron, you would not be able
It'd
to
be
do.
impossible. And if you did a
Right.
chevron cut doing this procedure, you wouldn't be able to do it either.
Right.
So, and I think it's important, really. So, I was kind of taught in school to be afraid of these cuts, to be honest, that the non-union rate was sky high, blah, 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 blah. That the fixation has a higher chance of failure, all these things. And,
Not so much.
Not so much. Maybe you could prove, I don't know. Maybe you could prove it somehow in the literature. I don't know. But as far as I know, I'm not seeing that.
Okay.
And I don't consider myself an expert at this. So I'm good. I'm okay,
Well, I think too sometimes that you made the comment, all bunions are not the same. And
Right.
that's so true because, sometimes, I haven't done a lot of bunionectomies for a long time since we started specializing in nerve, but sometimes you would get that translation, you'd get that tibial sesamoid over to where you wanted to see it on x-ray, and all of a sudden the joint didn't move because it had been in this
Correct.
position for years or decades, and now you've put this congruent joint into an incongruency, and it just didn't work.
And I would challenge people again. We're not doing this as an academic concern, right? We're doing it because people hurt.
Right.
Their sesamoids don't hurt.
Right.
That's not where their pain is. Their pain is on the bump.
Right.
So, and afterwards, even if you do Austin chevrons and that sesamoid position is still not so good, they don't hurt. I think that's a fairly rare complication, actually, is to have plantar sesamoid pain after the surgery. So whether you do a lateral release or not.
Well, everybody's concerned about, what range of motion. And, and if you're getting a great reduction of first MPJ dorsiflexion intraoperatively, well, that might say, maybe I don't want to line that sesamoid up so much.
Right.
And you have to make that intraoperative decision. Then it goes back to a lot of people are treating x-rays rather than treating people.
And and there's a lot of that is something to keep in mind as you kind of explore this kind of surgery, is you're not treating that x-ray. And we'll talk a little bit about that and how the x-rays look and what we're trying to accomplish here in a minute.
All right.
I guess valgus rotation of first metatarsal. Well, we're already there. So again, back to this straight cut distally. So to me, there's a movement out there now where there are surgeons that are using a lapidus for every type of bunion. Every bunion's a lapidus. So if your goal is to, and I've followed this literature for a long time, and I think they're spot on actually, as far as using the concept of the cora and finding out where the angulation deformity is and working from there. Yeah, I get it. But if your goal is to make that first metatarsal straight and put it where you want it, which let's say that's parallel to that center axis of the foot, let's say, in kind of a neutral foot. Congratulations, you succeeded with a Lapiplasty or that type of procedure.
Right.
However, so what if you have a Z? It doesn't really matter. I would say no, and you save a joint from being destroyed that's a good joint. And your body's already accommodated that joint anyway.
Right.
So you're not having pain there.
Right.
So to me, unless you have this monster IRA with a lot of flexibility, in which case I would say yes. If you're going to do a lapidus, do it the right way. I'm still fascinated by doctors who look at an x-ray and say there's no rotational deformity there.
They can't really tell on a two-dimensional x-ray.
It's there.
Right.
It has to be there in a way.
Right.
I can remember even when I was in podiatry school, I'd look at these x-rays and say, well, yeah, the sesamoids are out of position because the bone's on the side. Mm-hmm. That's why you have a bump. So this is kind of a distal lapidus, if you will. That's a terrible way to put it, but that's the heresy. Sorry. So you're really rotating that head, and you're effectively getting the benefits of the lapidus from that. As long as you don't have that hypermobility, that don't have to take that out of the foot. So those tend to be high IMAs, but stable feet, stable forefoot.
Now, what about metatarsal length? What are some of the
so metatarsal length to me impacts the implant choice to a great degree. So we're going to show some pictures of implants, and I'll talk about metatarsal length as being really one of the main factors. So why would you pick? So to me, I trained on several different systems intentionally. So, and this was one reason why. It's because that metatarsal length makes some of these implant choices more desirable than others.
All right. Well, we'll see that when we get to some X-rays.
Lateral release, we still have some doctors, everybody gets a lateral release. Some only if they track. To me, I hardly ever do a lateral release unless they have significant tracking.
Right.
So I hardly ever do.
Well, I think this may not play as much of a role in the small incision surgery or minimally invasive surgery, but when you're doing an open procedure and you're spreading everything apart, getting into that first inner space, there's just a lot of trauma. There's a lot more swelling, and I'm not sure that a lot of lateral releases do really anything except maybe let that chevron osteotomy slide a little bit more laterally.
Yeah,
that's it. Because your sesamoid still doesn't come into
no.
on it.
And if you're trying to do it to negate a deforming force, this procedure is so powerful because of that big lateral shift. You're overwhelming that deforming force. So I really don't think it matters too much. If anything, it may even add some stability to the forefoot that we might even want with this.
So go back to the first metatarsal length. Let's talk about if we have a really long first metatarsal, you want to get that shorter.
Yeah, which you could certainly do with this procedure. So right. Again, the magic of the burr. Mm-hmm. So you can do these decompression
right.
osteotomies with this burr fairly easily.
Right.
Once you get the hang of it.
Okay.
And of course, we do that with the saw all the time. Now this is different because, on your chevrons, obviously the Austins were doing these Youngswicks and whatevers, these if that's even correct. Sorry, Dr. Austin, Dr. Youngswick. But here you're cutting all the way through. So, and also sometimes I'll make a straight cut and I'll cheat it with the fixation. So that capital fragment, I will change the angulation of the capital fragment because I can put it anywhere I want and hold it.
So you can correct your posture.
I can. Right, so there'll be a gap there.
Yeah. But so what?
That gap fills in.
Right.
So we're not creating such an enormous gap that, we're violating our principles on Wolff's Law, blah, blah, blah. It fills in.
What is the osteocyte jumping distance?
Yeah, exactly. Exactly.
Right?
So it depends if they're,
if they're smokers.
Yeah, exactly. Or if they're Olympic quality.
Yeah.
So, yeah. So, and again, we'll talk about this when we see the implants. These are very rigid constructs. So the union is going to be delayed anyway. There's very little dynamization with these. In fact, I like to see somebody come out with an implant that does have some inherent dynamization to it, or at least a mechanism for compression. Most of these are fixed angle constructs, and they're very rigid, which is what you want because that's why they can walk on it the minute they go home. And so it's kind of a balancing act between the two. And it is a little, I'll admit, when you get to that 10 weeks on the x-ray and you're still not seeing a lot of bone growth in there, your Adam's apple kind of goes up and down a little bit as you swallow. But, at 12 weeks, these things are seeing solid bone. And at 15 weeks, for sure, these things are solid as a rock as far as new bone being built. And that's even with a little bit of a gap. And
have you ever thought about maybe squirting a little BPC 157
yes,
in there?
well, I've thought about squirting some BMA in there.
Yeah. But I mean, even maybe just a peptide like BPC 157.
I think there's different options you could do for sure.
Yeah.
When you're talking about any kind of an injectable, so most of these implants are going to be a small incision. So you're talking about maybe 4 or 5 millimeters. And you could definitely get something in there. Even on the percutaneous ones, then you're just talking about injecting, right? You just have to be, slick about getting it, put it where you want it to go.
Right.
So yeah, I think that those are considerations too. I have not done it, but
be interesting.
There've been a couple I've worried about, but they've all built bone. They may not be in this presentation under complications, but I've had a couple. Thank goodness, not too many. Maybe literally a couple, where it's like hardware removal, right? Some days it goes 42 seconds. Some days it's 42 minutes. So, don't
ever say, "Oh, that's really
exactly." It will be in and out of here. Right. So manipulating this capital fragment, especially these ones that are flexible, or where the bone is very soft and the fixation isn't holding maybe the way you want. Sometimes that capital fragment doesn't quite get into that best position that you want it, and you struggle some. So, but I haven't had any patient come back with residual pain post-operative down the road from that. The body's absolutely remarkable, and that joint, again, the joint's still there. So I think we have a pretty wide window as far as moving that joint around and still having a good articular surface, even though there is a ridge there on the first metatarsal head. But
you're talking about medial, like a little bit of a medial.
Yeah. So when I put these into a position to fixate them, I like to have it a little bit, the capital fragment, a little bit plantar flex, just a little bit, as opposed to should be no dorsiflexion, because I don't want to jam the joint afterwards. And then also, if I'm a little bit off in that transverse plane, I'm okay with it.
Well, let's move on.
Sure.
Get some more information here.
Yeah, and obviously the benefits are, and again, I kind of start with the patient. So patients are coming to me, and we're in a world now where everything is, I need it now. I can't be inconvenienced, and this kind of plays into that to some degree because, and then as far as other benefits, and I think this is significant. My patients are really using about 80, maybe even 90% less opioids post-operatively. So on a typical Chevron, osteotype procedure, they may take Percocet or Norco or whatever for up to a week, let's say. Here, it's usually a day or two.
Okay.
And in fact, I only write 12 pills. So, and I haven't had anybody come back wanting more. So then they switch over to Tylenol or maybe some ibuprofen.
All right.
So I think that's a significant benefit. And then swelling, most patients experience less swelling than a more traditional type open procedure. I think that this is an area where I'm still scratching my head some, and that is I have not been as good as predicting which patients will swell more than others. Mm-hmm. So that's an area that I'm still trying to struggle with, and maybe we'll learn more as we do more research on this or do more cases. And obviously quicker return to activity in sport. I get a lot of active people that want this procedure that have put it off for a long time, because of sport, because of their job situation or whatever, or kids, whatever. Post-op complications, there have been a couple. One, as I just mentioned, is the swelling. And then...
Well, is swelling really a complication or an expectation? Yeah, I mean,
good point.
I would argue that some swelling is absolutely expected. but maybe severe chronic swelling,
Right.
almost in like a lymphedema patient or something, is more of a complication.
Which I don't get on these.
Right.
So I mean, I guess my expectation, I guess it's comparative. So they swell some patients swell more than others, but all in all, 4 to 6 weeks, they're back into the same shoe size that they were in.
Okay.
So I haven't had any that have gone past that.
So let's go back post-op a little bit, because you said you allow immediate weight bearing.
I do.
When do they go back into their regular shoe? After you pull the stitches out?
No, I'm shooting for 4 weeks.
Okay.
So I'm taking the sutures out at 2 weeks, 3 weeks if there's a reason. They're slow healers, but yeah, I'm really looking for about that 4 weeks point to get them back into a shoe. And there's a few that don't make it at 4, but they've all kind of made it at 6.
So then you have them in a post-op shoe until you put them back into
Yeah,
the
sometimes
regular
take them out of the boot, put them into a post-op shoe, or yeah, I'm fortunate to practice in an area where people have some means, and I'm like, hey, go buy they don't have to be expensive, but go buy a pair of running shoes a size bigger than you have now.
Okay.
And that's
you'll put
temporary.
them at 4 weeks in that?
Yeah.
Okay.
Yeah.
All right. So this X-ray
is kind of I don't know, a complicated. This was a patient driven situation. So I think over the years I found there's two segments of the population that are probably the biggest liars in this country, and one are people who work in the White House, and the other ones are little old ladies. Okay. So that tell you that they're not walking on it. Or little old guys that go to the bathroom 3 or 4 times a night and tell you they're putting that boot on when they go to the bathroom. So this was a nice little old lady in that category, and she was walking on it when she had very soft bone quality, which I found out, intraoperatively. And she started walking on a little bit more, sooner than I wanted her to do outside the boot. And I'm walking on it a lot, actually. She finally fessed up to it. So I don't have the lateral on this, but the lateral, if you trust me, is in good alignment in a transverse plane. But, or in a sagittal plane, rather. So in the transverse plane, you can see the capital fragment slid proximally along the side of the med shaft, but the fixation held great.
Okay.
So I didn't have to do anything to this patient.
So you just watch this?
I just protected her, and she fused great in that position. And if you look,
it's amazing that would fuse with a cortex.
It is
next to a cortex,
and this screw provided enough stability for that to happen.
Right.
Also, I can't draw on there, but if you take a straight line down that first metatarsal, you effectively have a straight first metatarsal.
Yeah.
And she's a little short on her first met, but it's not hurting her. She hasn't developed any calluses. She hasn't developed any pain. She loves this thing.
It almost looks like it's a pretty normal metatarsal length, actually.
It does.
Yeah.
So you've kind of corrected that IMA.
Yeah.
In a way, but I wanted to show this because the fixation. There's some talk about with this system. I'm pretty sure this is a Wright Medical Striker Pro Step in which I only used one screw, and I think that's a 3/0 screw actually instead of a 4/0. And sure enough, it held like a charm.
Wow.
In soft bone.
Yeah. Well, when you look at that and you don't have any experience with minimally invasive surgery, this will give you a little bit of pause.
Sure.
Yeah.
I mean, I think their doctors put you in a cast for this.
Yeah.
So.
Or they would, we need to do an open reduction internal fixation and put a screw and plate on it and fuss around with it.
We just protected it, and it held fine. But that screw really didn't cut through the cortex much, even in what was, I can tell you, was very soft bone on this patient. And I've also had several cases actually of this aseptic drainage, and I've actually sent it out for analysis, and it's not joint fluid. It doesn't have any bacteria in it. It's clear, a little bit straw colored, and I think it's coming out of the medullary canal. I think because we're getting this great amount of shifting, we're exposing the medullary canal, and it's maybe coming out through the incision, basically. Even though I do suture all these incisions, but I'll tell you, I don't put deep suture in on these.
Yeah.
So
all of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
So when we start talking to the patient, the same thing you do for another analysis of a patient and preoperative evaluation. The only thing I look at is do a pretty good biomechanical exam on these people, and try to figure out what the reason is for their bunion problem in the first place.
So how often do you find yourself treating the equinus at the same time that you...
I have to say I don't.
Okay.
But usually it's more a foot control issue afterwards. I'm not putting a gun to these patients' heads saying you need a customized orthotic afterwards. But boy, I would really like to see them have some kind of control, especially if they're flat foot driven. Mm-hmm. Although I don't know what it is around here. I probably get, I don't know, maybe even more than half or cavus type feet with that medial forefoot collapse. So, and then obviously social concerns, and more about how much they need to be on their feet in the immediate postoperative period. And here's where kind of the heresy comes in. So, we're really looking, it really is a paradigm shift in the philosophy of how you approach these. These are next generation type implants. They look weird. They don't fit anywhere else into the classification of anything you've seen. But they maintain AO principles, and that's the key, I think. You're looking for this massive capital fragment shift. This is not a situation in which I'm trying to, do I need to shift that capital fragment laterally 3 or 4, 2 or 3 millimeters, right. One or the other. No, this is, you take one cortex, you move it to the other.
Right.
And that's where it goes.
So medial cortex of the distal fragment lines up with the lateral cortex of the proximal fragment.
Correct. That's what I'm looking for on really every case.
Okay. Which is a big correction. And that's why you can address a high IM angle.
You can. Yeah. And even on the low IM angles, I don't think there's any benefit to not moving it that far. Also, these implants are kind of built so that, especially the intermedullary implants, you kind of have to do it to get the implant into the thing. And
so what about the post-op recurrence? I would think that if you're getting that much lateral displacement, that the recurrence rate of these has to be negligible, if not.
I hope so.
None.
I hope so. Yeah. So I don't know that we know that yet.
What's your gut instinct on that?
I think if you're not treating the hypermobility segment of the patient population,
right,
I don't think it's coming back.
Okay.
I mean, these things.
I would even just empirically, I would think that even in a hypermobile situation, at least you're getting so much translation that it would really negate some of those forces that
you're at least maximizing what you got,
right,
without going proximal,
right.
I look at this and it's kind of like a scarf killer, if you like,
right.
pardon me if you like scarves, but
I like them in the wintertime.
yeah, exactly.
Right.
I'm not, and again, it kind of goes to the whole point of the thing, doesn't it? So you can get an incision that's three millimeters long, or a poke hole, or I can slice it from stem to stern and cut your whole bone longitudinally.
Right.
Yeah, it's like
very primitive.
Yeah, and why are you doing it? Because you need monster correction.
Right.
Well,
you get monster correction
with
now.
this.
Right.
Exactly. So it's kind of like, I call it a distal lapidus or a distal scarf sometimes, because I'm not I'm not careful with my language. So there is obviously longer time to bone consolidation, and that scares people, or it's at least it's a different paradigm.
Right.
So, 6 weeks for bone to heal. If I don't see that bone there, oh my gosh, I'm working on a slow union. No, you're not. So give it 15 weeks and that thing will be super solid. Immediate protective weight bearing still blows some people's minds.
Right.
So, even when these first started, so I trained under Bradley Lamb and Bob Bavarian. Bradley developed this first Crossroads mini bunion implant, and I think I'm pretty sure I was the first surgeon in Georgia to do one. And early on, couple of 2-3 years ago, I'd go to events and I'd be the only person in the room that had actually done one. Yeah. So that's changed now, but that's sort of where we're coming from on this. It's definitely an inside out technique. I don't know if that's got to come up with a better way to do it, but it's you're not looking at the bone. You're looking at the X-ray. Mm-hmm. So this would be more akin to putting an 8-hole plate on a tibial fracture and then percutaneously lining up the holes and shooting the screws. So this is more of that kind of mentality.
Right.
So it takes a comfort level with that. And of course, the whole point of it is to keep the incision small. And I probably err on the side of making them too small.
The incision?
Yeah.
Well, you can always link them a little bit if you need to.
And I do that quite a bit rather than probably making them what they should be to begin with.
Yeah. Well, let's see one of the...
Sure. Let's start taking a look at it.
I have a question for you in a minute. But,
So there are different types of implants. I've kind of put them in 3 categories. There's probably 4. One category is pins. So if you're using K-wire fixation or some kind of K-wire to create mobility, for lateral shifts, etc., I'm not talking about those. So these are true, what I would say are orthopedic implants. So the first category is screws. Right now, there are several different manufacturers that have a screws-based system, and the ones I'm going to show you are the ones that only have one screw. So this is one that was a little bit of a challenge to me. This was a short metatarsal, right? So the challenge is soft tissue. So when you have that short metatarsal, your entry point, and here I cheated the entry point as distally as I could put it. Really, I'm shooting for that proximal flare at the MC joint. That's where I prefer to come in. There are also some limitations on screw length for some of the systems. But in this case, to get that screw in, I've got to evert the foot of the patient intraoperatively. And so for patients that have a soft tissue, fat ankles, for lack of a better word, this can be a challenge because I can't drop my hand low enough to drive that screw, to drive the wire for the cannulated screw. And early on, I think I did burn 1 or 2 patients. There's tissue protectors, but at some point you just can't. Right. You can't hit the angle.
Right.
And you sure as heck can't put 2 screws in. So
that brings to the point.
And that's why we didn't get the big correction.
Well, it brings the point that, what is one of, comorbidities like obesity, high BMI, decrease surgical outcomes for many reasons. But one is just intraoperative manipulation and movement of the extremity to a position where you can do what you need to do. But that's tangential, but I think it's a good point.
So on this, I don't have a slide about room setup, but it's really of paramount importance. If you set up your environment to do these surgeries inappropriately, you're going to block yourself.
Absolutely.
And one of the things you need to do is make sure the foot's far enough off the edge of the table. You need to make sure that the table is set up so you could shoot through the table sometimes. And then also, don't block yourself on a tourniquet situation. I go mid-calf on almost all these patients.
Now, let's talk about tourniquets. I was going to bring that up a little bit. In Europe, they don't use tourniquets because their philosophy is they want the blood to cool the bone as the burr, is turning in there. And it was, you'd look at them intraoperatively and it looked like some kind of horrific thing because there's blood everywhere. And it was just, and I never really bought that philosophy. And when I started bringing those techniques back from Europe, and I slowly integrated them, but I would always use a tourniquet, and I never saw any delayed unions because of this temperature or whatever. So I thought, there's academic considerations and there's reality.
Right. And there's reality, and then there's reality. So one of the realities is your facility is going to love you if you have clean, quick procedures. And with a tourniquet, this is a lot cleaner. Right. And once you get used to it, it'll be a lot quicker.
Right. So, well, and then, you talk about just the positioning of the foot. You have a bunch of bleeding, and I would see the surgeons in Europe, they're slipping. And,
that is true.
So it does impair technique a little bit as well.
Yeah, I can see that. And then on this one, I got some correction, and then I lost some of the correction when I put the screw in. So, but you can see I still got a shift that was darn near close to what you would get with an Austin.
Oh, easily. Yeah.
So,
and your sesamoids are lined up.
Sesamoids look decent. Yeah. And then you can even see on this X-ray, that's a really horrible ache, and I apologize. But this was one of the very first ones I did, actually, and I wanted to show it. And then you could see the bursal sac there. But my point is going to be that very rarely do I have to go in with the burr and shave down an eminence, a medial eminence.
Because you're moving it over. Right. And that actually gives you a little bit more lateral displacement possibility, right? Because when you stake the metatarsal head, you have less to move over.
And I don't go in and try to do anything to the bursa.
Yeah.
I let the body, nature will take care of that. And I talk to the patient about that.
Well, it's interesting. I mean, this is reflective of what you talked about a little earlier about learning curve and everything. I remember I was at one of the MEFIS meetings, and they're great. I mean, these are the top orthopedic foot surgeons in Europe. And I was at a lecture one day, and one of the top MEFIS surgeons there gave this presentation, Complications of Minimally Invasive Surgery. And he had all of these horrible things. And I'm thinking, wow, this is crazy. And I said to him after the talk, I said, man, who all screwed up all these people? And he goes, I did. That was my learning curve. And this is one of the top surgeons in the world.
Sure. There's a learning curve to everything.
Right.
And a learning curve shouldn't stop you from learning. Yeah. So also, if it really bothers you that there's one screw in there, you're more than welcome to run a pin in there and take it out later.
Right.
Or bury a pin if you so choose. I mean, there's nothing stopping you from doing that. There's enough room to do that sort of on this one. But I haven't had these derotated.
Okay.
And then the second type of implant are these fixed angle devices, which are kind of just like blade plates.
Okay.
So this is one made by Crossroads, it's called a mini bunion. It incorporates a locking screw into the capital fragment and a non-locking screw bicortically placed that helps maintain stability in that proximal portion of the implant. I like these implants. They're super solid. They kind of force you to put that capital fragment in pretty close proximity to where your cut is on the proximal side, because the way the screw is. It's a fixed angle.
So let me ask you a question. You're talking about maximally laterally displacing this capital fragment. Well, there's only so far that you can go, and that's because the second metatarsal is going to stop any. Right. It's a doorstop, so to speak, right? Yeah. So obviously, high IM angles, you're going to be able to get more of this lateral displacement.
Also, metaductus,
something like that,
is a consideration. Yeah, and this is off of their website. So hopefully we've got one of mine on there. I get cortex to cortex creation with this device. So when you place this device in the medullary canal, my feeling is it finds its point based on where you're trying to place it distally. So that distal portion is going to dictate, because it's a fixed angle device, where that proximal, this piece over here, ends up entering into that metadiaphyseal hard bone. And once it sticks, it sticks.
Right.
And it's a very solid construct. And then when you put that bicortical angulated screw there, it holds really, really well, even though it only has 2 screws.
And you do nothing then with the little overhang medially?
So that was something I was worried about when I first started doing these.
Yeah.
And there's a little controversy amongst the different doctors. Some want to do it and some don't. Sometimes the patients feel that.
Right.
So if I think the patient's going to feel it, I'll go in and I'll try to burr it down some. The only thing with this implant is you don't want a really, really messed up pasa on this one, because you're not really, because it's a fixed angle device, you don't have a lot of wiggle room on that.
Well, let's say that you couldn't get the capital fragment to do exactly what you wanted it to do from a pasa standpoint. You could always cheat that with an Aiken. Correct.
You can, and I like that, because that is the whole point of this, is that you're not trying to make the whole first ray straight as an integral part of your correction. The combination of angles has to kind of equal that straightness, right? I said that terribly, but you know what I mean.
No, so when you look at the foot without an X-ray, you can tell whether the hallux is lined up or not. You don't care how curvy the road is between A and B, which is what you're going to see on an X-ray, right? So
yeah, you want alignment with that
clinical alignment.
Yeah, exactly.
Radiographic alignment.
Exactly.
Yeah.
And the other thing with this is you've got just a little bit of wiggle room on this device to take that capital fragment and rotate it in a transverse plane to pick up your pasa. There's not much room there between that angle where it starts to angulate into the medullary canal and where the screw that fixates into the capital fragment is. That's a very small. There's not a lot of wiggle room there. It has to be buried deep enough so you can put this bicortical screw in there.
Okay.
But I don't know if it's the most solid device or not. It probably isn't now, but I love it. I've had people fall the day after surgery,
and they're
significant falls.
Yeah.
Didn't move a millimeter.
Well, let me ask you this. So you've got a relatively small incision. I can see easily how you can create your osteotomy. How hard is it then to snake this thing in there through that small?
Yeah, so I like this device because it has an inserter handle.
Okay.
Which I just, in my hands, I like it.
Okay.
So I can use one hand to control the position of the capital fragment and the toe.
Mm-hmm.
So, and this is what we talked about earlier, this little artistic part of it. I'm putting it where I need it. I'm watching it on the X-ray. Then I'm inserting.
Got it.
With my other hand. And on the lateral.
Do you have to sometimes lengthen the incision to get this in there?
I have had to do that a little bit.
Okay.
Sometimes.
Yeah.
It's about 5 millimeters max to
Okay.
get it in there. I can cheat it a little bit on most patients.
Okay.
You just need to get it in and then get to that bicortical non-locker. So it's super strong, super stable. Patients don't have a problem after Yeah, let's do that. So let's move on to the next type of implant or general category, and that's what I'm calling intramedullary devices. And there are several. This is one that I've done, and it's called the Central Lock by a company called Novastep, who also has a two screw fixation system called PICA, which is a percutaneous system. So with the Central Lock, you have these two derotational screws as part of the intramedullary tube piece, I'll call it, and then you have a kind of a pretty robust fixation system in the head. So if you're concerned about one screw in the head not holding, here's three. So
isn't that sometimes too much?
I worry about blood supply sometimes, to be honest. Yeah. But I don't think that's been proven to be an issue. Okay. It's just something that was in my head.
The first thing I thought was an avascular necrosis.
Yeah, exactly.
Screws in a small piece
exactly. Yeah, and I thought about that, but I haven't seen those happen. Not on mine, and I haven't heard of them happening, out there. It is a fixed angle device as well. This is really a truly fixed angle device. And the step off is built into the plate on this one, into the device. So that's it. I mean, that's where you're going to get your step off. There's very little wiggle room as far as translation. They account for it with a sizing system for the implant. So there are different sizes, which will end up giving you a different lateral translation. So probably a good time to talk about systems that have jigs and types of jigs and things. So I'm not. So I think that we've gone through an era that's probably too strong, but we're in a phase right now where for the manufacturers to pick up more surgeons who get comfortable doing this kind of surgery, to kind of take some of that artistic kind of feel out of it, we've gone to jigs. Okay. I find jigs to be a pain in the ass. So it's, for me, unless I really need a jig, which a jig will come in handy for these proximal screws, I totally get it. Right. But other than that, maybe it's just my fumbling and bumbling, but jigs get in the way. Okay. They also become an issue with soft bone. So, I don't think we have a picture of one system that I've used. And in soft bone, I basically had to take the jig off because it just would not hold. It kept moving. And there wasn't a way to fixate it. So I freehanded it. It's not the easiest thing to do with these proximal screws. It's not a tibia. It's right. So you're not shooting across this bone with the overlap of the other toes. You're not going to see that perfect circle type situation. So, but is it impossible to throw a K-wire through that hole? No. Right. And I've done it. So, but.
And those are cannulated screws, or they're not?
These are not.
Okay.
The proximal ones are, but the capital fragment ones, you visualize those. So it's a bigger incision. Okay. It's robust. There's no doubt about it. And it's very derotationally driven. So, but in the overall scheme of what I see, I can put less hardware in and still say is robust. Okay. It's my gut feeling.
Well, you have a lot of inherent stability just from the intramedullary component itself.
And this one really fills up more of that medullary canal.
Yeah.
So to me, these are the three main types of implants or categories of implants. Like I said, the ones that are pin-based or K-wire driven, I really didn't include here. There are going to be new ones developed. I'd like to see some new development in the area of how do we create some compression on these devices. I think that would be helpful. I say that, and then in the back of my brain, I hear a little voice yelling at me that it's already super stable. If you compress it, it's even more stable, you may defeat the purpose. You could even have bone, loss in that situation.
What's the greater enemy of good?
Perfect.
Better.
Yeah.
Perfect. Right.
Exactly.
Right.
So, if it doesn't break and it takes, what does the patient care if it takes 12 or 15 weeks for bone to develop? They've been walking on it since week 4.
Exactly.
So, it matters to me and my silly little x-ray,
Right.
but it doesn't matter to the patient. And that's what I think should drive this whole approach to forefoot surgery. It should be pain and deformity driven. The other thing is, I don't know if it's just my situation, but a lot of patients are coming to me for the surgery. They don't have that second hammer toe.
Mm-hmm.
And it's either they've got flexibility to their forefoot and they didn't get it, or they've controlled it some, or just genetically they didn't develop one yet. But their biomechanics are such that I'm not getting it. So when you're doing this with a second hammer toe, I worry way more about the hammer toe than I do about the first ray. So depending on what you're doing, the second hammer toe, is going to determine weight bearing status and protection and stuff like that, and ambulation.
Well, I'm pretty impressed with the fact that they've developed these types of internal fixation for minimally invasive procedures, which is a big advancement. And I think, if you're going to be critical about minimally invasive, it's really comes down, it's oriented to complications. And where a lot of people got in trouble was they just didn't use any sound principles. They made these osteotomies that were inherently unstable and they provided no fixation. And then they let them walk like crazy on it. And guess what? They ended up with a mess. But, the techniques, the surgery itself has evolved to a place where if I was a patient, I would want to have this rather than a lapoplasty by far. I just think it's, now granted, I've always been pretty minimally
right. Me too.
Invasive oriented. I mean, obviously with the endoscopy that we've done and those types of things, I gravitate towards less is more. And, you made a great point about opioid usage, and, less opioids are obviously much better.
Sure.
And that correlates with usually how patients are ultimately judging the procedure. Because what do they judge it on? They judge it on how much pain did I have? How much was I debilitated? How long was it till I could get back in? And what's the ultimate correction look like? All those things are very important.
Yeah, I recently operated on a patient that, and this was pretty satisfying for the patient and for me, where they had received, they had lived in Ohio. Mm-hmm. And he had lived in Ohio and received that typical kind of medial, 4.5 pounds of metal in there. Works great, very stable, but he also had something else, but it was a tough time for him. He was not happy with the surgery. He was very concerned about having his other foot done. That was not a good experience for him. He was off his feet, pretty significant pain, and just wasn't happy with it. And it took me a little time to bring him around on this. Obviously, no guarantees, no warranties, all that stuff, right? But I'm like, this isn't going to be what you went through before.
Right.
And at a week and a half, I saw him, and he came into that office in that boot, walking, almost dancing, coming in. He was so happy. So to me, that's kind of the whole point of it.
Right.
And I know that I'm getting correction. I'm picking a procedure that makes sense.
Right.
And I didn't cut out any good joints. And I got this, what I call, that effective correction in the IMA. So, and
I like it. I think it's,
I think it's going to take over actually. Yeah. And I think the future holds, as newer learners are coming down the pike, this is going to be kind of a go-to procedure for them. I think that the fact that you see so many manufacturers investing in these implants speaks to that.
Yeah.
I don't know how many more implants we're going to get, or how many ways you can skin this cat and still have it be pretty small incision. But as far as percutaneous, I've had good success with 1 or even 2 screws. There's a local orthopedic surgeon done well over 100, if not many more than that, actually, with just screws the whole time,
right,
and has had really good success. And that's percutaneous.
Now, are you splinting these folks pretty well with your?
No, I'm not doing anything different.
Okay.
In fact, I wrap them less.
Okay.
Yeah. I mean, unless I've got kind of a tenuous hammer toe that I've dealt with, I put less dressing on these people, actually, because I think that they're just more comfortable, and they don't hurt afterwards. And I'm not afraid with that 1 or 2 little 2.0 screws that you stick in an Austin.
Right. Yeah.
I mean, these are robust screws, and on the screw-based systems, if I can, you're looking at putting a 4.0 and a 3.0 screw in there. I mean, this is a fracture fixation.
Yeah.
So, that's basically what this is. To me, this is a lot of hardware for this.
Yeah.
So if you're looking at it from that perspective, this would be on one end of the spectrum right now for me.
Patrick, thanks so much
for
taking your time.
Happy to do it.
And I know it was a horrible commute. Took you almost
it really did.
It was more than 30 seconds. You said 13 seconds, but yeah, no, I love hanging out with you. The fact that you're actually a neighbor now.
Yeah, it's amazing.
Like, it's crazy, right?
Yeah.
I mean, here we are in Jasper, Georgia.
Who would have thought?
Who would have thought that?
Yeah.
But
yeah, and Atlanta is a great place to practice medicine and our kind of medicine, and I think this is going to take over. To be honest, I'm surprised it hasn't yet. I'm certainly happy to help anybody I can help do it. Like I said, I'd like to get involved with. I wish I could do more on the research front, but there's plenty of people working on that now.
Right.
And I'm looking forward to their results as well to see if we have to tweak this thing or if we have any.
Well, I'll put in the show notes how folks can get a hold of you.
Yeah, sure.
And I'm sure there'll be a fair amount of patients that reach out to you, because when a patient sees this, even though they may not understand all of the esoterica that we've dived into today, they get it. They understand, because they're on the internet,
right,
and they're looking at all these things, and they want the most advanced.
And some of these are advertised to the general public. And I was on the treadmill at the gym the other day, and I saw a Lapiplasty commercial.
Interesting. Yeah.
So
it's kind of like Big Pharma reaching out to you.
Yeah, it really is.
Medicines.
And once we start having that discussion, patients come into my office having seen something like that, and then, well, maybe they need an MC to be addressed at the MC joint. Fine.
Right.
I do Lapiplastics too. But if maybe they don't.
Right.
So it's that's part of our professionalism, is to guide them into what they'd be best served, as far as the actual surgical procedure. So that's basically it. I'm looking forward to doing more of them. So far, so good. I mean, I've had pretty limited complications, and patients have been happy. So we're going to keep doing what we're doing.
So I have to make a comment now, just to wrap this up, about the heretic of Hallux Valgus.
Yeah, that's right.
But what's real important to realize is that when you bring something new or you challenge an existing paradigm, it's labeled heretical. And then 10 years, 20 years down the line, you become a hero. You're no longer a heretic. There's this transformation. I've lived it, and it's hard. I mean, the medical paradigm. I mean, once these things get entrenched in these guys' minds, it's really hard to overcome decades of training and conceptualization.
And, to some, in many cases, that's how progress is driven.
Right.
We don't tend to, something that just pops into my mind. For those surgeons here that are doing external fixation, big external fixation. If you look at limb lengthening procedures, we were doing big external rings, we're doing talar spatial frames, et cetera. Now we don't. If you look at the new era of this, we're sliding people on a nail. So, more minimally invasive, if you want to put it that way, in a way.
Yep.
But constantly changing, and in this case, kind of circular.
Right.
It took a foothold years ago, but I don't think it was the actual procedures and philosophy. I think it was some abuses that were made into the system that kind of derailed it some. So I'm glad to see it back. I think it's good for patients. Patients are certainly happy. These are quick procedures. Once you get, acclimated to using the equipment and what you're doing, they're fun to do.
Right.
They're really fun. And, you're walking out of this room with, in some cases, just a couple stitches.
Yeah.
So, it's amazing.
Well, it's that speaks to the power of minimally invasive surgeries. You can really create some incredible reconstructions without a lot of tissue destruction.
Yeah.
And then patients are really happy.
And we really didn't get into that. We didn't get into some of the internal tissue destructive portions of this, or theoretical tissue destruction. We didn't really get into some of the, it remains to be proven, but I think it's just kind of empirical or common sense that smaller incisions, less chance for infection.
Yes.
Makes sense to me.
Yeah.
So, I think that's there too.
Well, it's also faster healing because you haven't compromised the vascularity as much as if you strip the periosteum and entirely off the bone. And that goes on. We probably should do a follow-up where we talk about, maybe go into a little bit deeper dive.
Well,
this is a good overview.
And there's some issues related to this. So what do you do with a patient that you think, hey, they'd be well served with a minimally or a small incision surgery for their hallux valgus correction, but they've got a metaductus. What do we want to do with that? And how do you address that? The Lapiplasty system does have also a corresponding metaductus addressing system that uses, I believe it uses some type of a jig. And don't be, I would challenge people, don't be afraid of your own skill set. You don't need, you can do it. Right. You can manipulate this thing. You really can be your own jig in a way, for most of these. Now, some of them, they build it so it requires it. But, if you've had any experience fixing many fractures or trauma, you perk screws all the time.
Right.
So this is no different. It's just be smart about it. So your hallux valgus angle, length of the metatarsal, we didn't get too into it, but, I talked a little bit about the soft tissue, but also just the angle, just getting the pin in. You have to go back to your techniques, and you come in, break the cortex, drop your hand. You just got to do the basics. Right. I don't measure anything. There's some systems now that have a device that will measure that lateral shift preemptively. Some people will, and I do this now. I didn't at first, but I start the pin just for this 2-screw system, or 1 screw if I want to do 1 screw. I'll run on the pre-op x-ray, I'll kind of lay a pin over it if it's close, and I'll visualize in my mind's eye where that fragment's going to translate, and then see where we're going to catch it.
Okay. Yeah. So I understand what you're talking about.
Yeah. So I'll pre-drill that pin and put it through there, translate it, and then just pop it. Or if my hands are full, I'll have the assistant, run it into the capital fragment. So
I can't think of a better way to spend a Saturday afternoon, have a little wine and education. And
absolutely.
So we'll have to do it some more.
Absolutely. Love to.
All right, cool, man. Thanks so much.
Thank you.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry.